Good evening, everyone. I'm Dr. Pankaj Kumar. I happen to be the chairperson for the Biological Psychiatry Specialty section of the Indian Psychiatric Society. First of all, a warm greetings to all of you on behalf of the Biological Psychiatry Specialty section. It is our immense pleasure and honor to welcome you all to the 2 days webinar on a very important topic that is imaging in psychiatry being organized by our specialty section. I want to extend my heartfelt welcome to all my office bearer of the national body who has taken time from their busy schedule on such a short notice to grace today's occasion. I'd also like to welcome all my distinguished speakers and chairperson who has agreed to be part of this presentation to this seminar. And we are looking forward and excited to have a very delightful and enlightening session for today's webinar. Not last but not the least, I'd also like to welcome all my IPS fellow members, my seniors, my colleagues, my junior friends, and at the end, all the participants from all the fields of mental health who have given their time to participate in this seminar. With this brief welcome, since we have the honor and privilege of having presence of our national body president, general secretary, and treasurer, I'd like to first have the opportunity to invite our national president, Dr. Binay Kumar sir, to say the few words. Over to Dr. Binay Kumar sir.
Thank you, Dr. Pankaj, for kind invitation. Actually, when biological psychiatry specialty section organizes a program, it becomes very important. Now, the thing is, there was a time when we were developing software for every hardware. Now, in psychiatry, things are being done other way around. For us, the whole subject was software. Everything was mind and psychotherapy and psychoanalysis. Now we are going other way around to found what are the hardware connections are, what are exactly happening at which level. So it's a kind of different kind of journey altogether. And this tells about the importance of biological psychiatry, and this tells about importance of neuroimaging. We all know that neuroimaging is not about only X-ray and only CT scan. Things have improved much ahead. Now we can assess all functional components. We can assess things real-time situations, that if somebody is thinking something, if somebody is not thinking, if somebody is angry, what areas of brain are active or what area of brain are we having in which way. So things have changed much. This tells about the importance of neuroimaging. I congratulate the team led by Dr. Prabhakaran, Dr. Pankaj, Dr. Sai Krishna, Dr. Manik Visay, that you have organized a beautiful program, and I'm sure this is going to be very illuminating, and learned speakers will tell us, Dr. Patel, and so thank you very much for inviting to say a few words. When the discussion is about some certain topic, we all are listener and we all are students. So I'll be in the meeting as good student and will continue to be like a good student throughout the meeting. Thank you very much. I'm sure this evening will add many things to my knowledge. With these few words, I hand over to the organizer.
Thank you very much, sir, for your brief but really encouraging address. Now, I would like to invite our Honorable General Secretary, Dr. Arvind Brahma, sir, to say a few words. Over to Dr. Arvind Brahma, sir.
Thank you, Dr. Pankaj, for the invitation. Basically, uh, this particular subcommittee is very important from the IPS point of view, because what our President sir has just told, this biological second subcommittee, we're having a webinar on neuroimaging. I think this is very important because we know that neuroimaging is a core component of psychiatric research these days, and it can differentiate in the brain system that underlying the brain illnesses, second different mental illnesses, or the treatment response and the properties of brain function carries the risk of disease. So I think we have two very good speakers, Dr. Sndeep Mevada and Dr. Drushi Patel, so we can learn a lot from them. And Dr. Marwale and Dr. Deepak Tiwari sir are the chairperson, so they can also add their wisdom in this very important topic. And this is especially important to us also for the seniors, because now the current updates about the neuroimaging, especially in psychiatric practice, we are definitely getting lots of good informations attending this webinar. So thank you very much, Biological Psychiatry Subcommittee, my dear brother, Dr. Pankaj, Dr. Sai Krishna, Dr. Manik, and advisor as Dr. Anil Prabhakaran sir for choosing this particular topic and inviting me in today's program. So thank you. Thank you very much for invitation. Over to you, Dr. Pankaj.
Thank you, sir, for your kind blessings. So now we have our another very important office bearer, our honorable treasurer, Dr. Alim Siddiqui, sir. And sir has been already conducting a series of webinars which has made lots of headlines and breaking lots of records. And he has tried to cover the whole range of topics which are relevant for today's time. So I definitely very excited to hear from you, sir. So kindly express the few words, please, sir.
Thank you, Pankaj sir. Thank you so much. Thank you so much. Wonderful being in this webinar. As we were talking before, we were planning a series on this, but I think you have given us a brick and mortar to start this structural imaging, functional neuroimaging. I think this is the most basic from which we should start. My respect and regard to all the office bearers, the speakers, Dr. Sndeep, Dr. Drushi, the biological psychiatry subcommittee, Dr. Prabhakaran, Dr. Pankaj, Dr. Sai, Dr. Manik, Dr. Vishal, to the chairpersons, Dr. Marwale and Dr. Tiwari sir. So I think very important start, because most of us actually do not know how to read an MRI. So I think a rather more basic thing would also be welcome. That is one point. And another thing, I was eating this around AI. I think AI is now interpreting these images, structural, functional imaging, so various sort of permutations, combinations. I think superseding human reading of this. So I hope it is discussed in somewhere in the webinar. So, with these words, I congratulate you once again on a very important, very clinical, a bread and butter topic for us. So, thank you so much to the committee for organizing this, and back to you.
Thank you, sir, for your encouraging words. So with that brief welcome and speeches by our national office bearers, now it's time to start the webinar, which is the main topic, which is the main thing for which we have today gathered in such a good number. I could see the 100 number of participants. So, as we all know, the topic is imaging in psychiatry, and earlier our national bearers have highlighted how our quest for neurobiological understanding of psychiatric disorders has the very foundation first into the imaging, particularly when you talk about the structural and functional imaging. And over the last 35 to 40 years, it has tremendously increased the our understanding of the various neuroanatomical aspects of various mental processes, various neural network connectivity between the various brain regions which are subserving our different mental processes, and how and what happens when we are doing the task, when we are at resting state, what happens to our living brain in terms of changing connectivity, changing the activity and metabolism. So all these basic aspects of understanding of the structural and functional imaging has taken us to a level. Now we are thinking about talking the understanding the biological causation theories, though we are still far away from that theory, so that we can come from the lab to the bench side. That is still a far to come, but still a lots of information and advancement has given us much more knowledge and understanding to further carry out research to understand this neurobiological mystery. And I'm very sure and excited that today's two topics and the speakers, they are really going to give us a very useful and informative deliberations to make us prepare further to advance all this technology in better understanding of the neurobiological aspects of various psychiatric disorders. With that brief opening of the topic of the seminar, now it's time to invite for the first session, our chairperson for that session. I'd like to introduce the chairperson, Dr. Deepak Sachdanand Tiwari sir. He is currently working as a professor and head of department at GG Hospital, Jamnagar, and he is also in charge medical superintendent of that hospital. He has a long 28 years history of working as a teaching, training, and research faculty in the field of psychiatry, and has held various positions as a faculty in various medical colleges, including BGMC Ahmedabad, Government Medical College Bhavnagar, and Government Medical College Jamnagar. So it's our pleasure and honor to welcome you, sir, to this seminar, and I hope that this topic and this session will be very helpful. With that brief introduction, I will invite now Dr. Deepak Tiwari sir to take over the session further. Over to sir.
Thank you very much, Pankaj sir, and especially with the blessings of our IPS Society, President sir, Brahma sir, Dr. Siddiqui, and Vinay Kumar sir. It is a pleasure that we have a very good and experienced speaker with us, Dr. Sndeep Mevada, who is head and senior consultant radiologist at Sanya Diagnostics and Sahyoj Imaging Center. And there is a huge amount of work being done at BGMC Ahmedabad. So he comes with a loads of experience of working, and with a special interest in neurology and GI imaging. He is also working at Janki Imaging Nadia, and he holds a position as a treasurer in Gujarat State Radiology Association, and also he has a vast experience of having more than 50 lectures delivered at national and international conferences. Sir, we are very grateful that you are speaking with a very good amount of 100 participants with us. Dr. Mevada, sir, please. We welcome you and you can begin. Thank you.
Now, am I audible?
Yes, sir.
Yes, sir. Sir, we would request some other voices
Thank
to
you very
stop.
much. Well, thank you very much for giving me an opportunity to present a topic neuroimaging. Initially, that was the they are sitting in the room and doing imaging and white imaging. Days when some interest in this branch, our taking some interest and bilateral talk, then a good opportunity to have a perception in regarding to neuroradiology. As Dr. Siddiqui has said, psychiatrists or most of the psychiatrist students even don't know how to read the MR basic. 20 minutes, we will discuss about neuroimaging, how the structure of the brain that is relevant to the psychiatrist, and at least what I expect from the psychiatrist, that which investigation you should go, what basic thing you should know about as a psychiatrist, and what investigation or what about the recent advance and imaging modalities you should prescribe to the patient, and you should ask or discuss with your radiology colleagues. So I'm going into much detail. So my today's topic is structural neuroimaging. It is a very, as Sir says, that it requires a series of the lecture, but I will try to cover within short span and briefly. What is structural neuroimaging? So in next 20 minutes, we first go with the introduction, why neuroimaging in psychiatry. Then we will the basic principle of the imaging and its modalities and its sequences. Then we will discuss neuroimaging in specific psychiatric disorder, and then we will conclude. So as we know that neuroimaging allows measurement of structure, function, and chemistry of the human brain. Over the past decade, study using this method have provided new information about pathophysiology of psychiatric disorder that are proved to be useful for diagnosing illness and new treatment. Nowadays, in addition to the structural neuroimaging with CT and MRI, with recent advancement of the MRI, with recent advancement of the further imaging modalities and further sequences, we can actually evaluate the chemical composition of the neuron, chemical structural changes in the neuron by the functional neuroimaging. So that functional neuroimaging enables scientists and clinicians to obtain insight into the disease human brain. So it can be useful for diagnosing illness, predicting the prognosis, and for the development of the new treatment. So why neuroimaging in psychiatry? As we discussed, it help us identify the neural system abnormality that are more accurate than traditional clinical measures. And the recent branch or recent advance, the functional neuroimaging techniques have an adjunctive role in the evaluation of the dementia and seizure disorder. And by all this neuroimaging, we can do better classification system of psychiatric illness. So the type of neuroimaging we divide into structural neuroimaging and functional neuroimaging. My colleague Dr. Drushi will take over, will discuss about the functional neuroimaging. So today's my topic is based more towards the structural neuroimaging. See, this is not about that two separate entities. The structural as well as functional neuroimaging are the combined imaging techniques to evaluate the disease process. So today I will discuss about more towards the structural imaging. In structural imaging, the routinely what we do, CT scan and MRI. The plain skull radiography and pneumoencephalography, they are mostly more or less theoretical value. They don't have any practical value. So first we will go with and in functional imaging, the recent advance like functional MRI, PET scan, SPECT scan, MR spectroscopy, diffusion tensor imaging, and brain electricity activity mapping, that is also called the beam imaging. So first we will go basic of the CT scan. As you all know, the CT scan are based on the X-ray. So it takes a series of head X-ray from all vantage point of view, particularly 360 degree around the head. So the basic principle of CT scan is that the amount of radiation that passes through or not absorbed from the each angle is digitalized and entered into the computer. the computer or the software and assign a specific density to each point within the head and display this data into the set of the 2D images. When viewed in the sequences, these sequences allows mental reconstruction of the structure of the brain. So depending on the penetration of the X-ray, the tissue shows different density. In different density, they give different appearance. As we see, the bone gives white, calcified appears hyperdense or it is white, blood or calculated blood also gives white, gray matters appears light gray, white matters medium gray, CSF, water, they are just like a jet black. So CT image determine on the density of the tissue absorbed by the X-ray. So bone tissue absorb large amount of X-ray and tends to obscure the detail of neighboring structure. So this gives poor visibility in the brainstem. That is also called the beam hardening artifact. So it also CT has poor differentiation of gray-white matter and MRI. Certain tumor invisible on CT scan because they absorb as much as radiation than the surrounding brain tissue. So that require further evaluation with the contrast CT scan. So bone, blood, calcified tissue and contrast material all appear white and it is also called the hyperdense and CSF appear black. So the only component of MRI brain that better seen on CT scan is calcification, which may be invisible on routine MRI. So some important structure that we should know So whenever you get a plate or get an image of the CT scan, you should know at which level this section is taken. So this is the first section usually. It is in the brainstem lesion. In foramen of magnum, you should at least identify this is cerebellar tonsil, that is medulla. Once you go up down, then there is a cerebellum. Now you can see there is multiple artifact because of that it is surrounded by dense bone. So it gives multiple artifact and it is called beam hardening artifact that gives limitation to the CT scan. Hence, the brainstem and posterior fossa structure is not better visualized on the CT scan. So MRI has a much better role in visualization of the brainstem as well as the medial temporal lobe that are more important for the psychiatric perspective. If you go upside, then you can see the pons, cerebellum, medial temporal lobe. Again, upside, you must see the basic structure. There is basal ganglia lesion and there is a frontal horn. Just lateral to the frontal horn, there is a caudate nucleus. You can see this white matter, hyperdensity. Just lateral to this, there is a small compact bundle, if visible, then it is called internal capsule. Just lateral to the internal capsule, there is lentiform nucleus, which is again divided by the globus pallidus and putamen, which cannot separate on the CT scan that require MRI. Similarly, if we go higher up, then the frontal horn, third ventricle, and all the structure visible. So, criteria for the contrast. As a psychiatrist, when you should advise for the contrast, patient with history of the seizure, patient with history of CVA, when you want if there is any vessel block or not, or suspicious of intracranial SOL, including granuloma, tumor, or metastatic lesion. But nowadays, after plain CT scan, most of the radiologists prefer to go directly to MRI because contrast CT scan has some limitation or it require to inject the dye. So my suggestion, if patient with history of seizure or cerebrovascular accident, or if you suspect granuloma or tumor or metastatic lesion, if MRI is available, you should directly go for the MRI. So plain density has an accuracy of 82%. Once you inject the contrast, it has accuracy of 92%. Contrast gives hyperdense structures. This is the plain lesion. You cannot see any enhancement or any lesion in this structure. But in here, after contrast administration, there is a fluffy enhancing area. So how this contrast enhancement looks. So advantage of CT scan, as we know, it is simple, cheaper, more easily accessible. It tolerated by claustrophobic patient, As such, no absolute contraindication for head MRI. It gives it has ionizing radiation, so it is contraindicated in pregnancy. But for head CT scan, we can do with the lead shield if clinically indicated, and it has a better or advantage as well as calcification. Radiation, it has its own complication of tissue contrast. CT brain in psychiatry, when you should advise CT brain when there is a confusion or dementia of unknown cause, first episode of major affective disorder, personality changes, or psych, and has already psychiatric symptoms and developed seizure, no neurology, or accompanying by psychiatry, CT scan, also called magnetic resonance imaging. So it has very complex. Basically, are thought to spin about an axis space. So then field. So axis of all odd number nuclei, mainly hydrogen, align with the magnetic field. So radio frequency waves, axis of nucleus deviates away from the magnetic field, and this, when the pulse terminates, the axis of the spinning nucleus realign itself with the magnetic field. During this alignment and realignment frequency signal, scanner collect this individual analysis and generate interpretates frequency and magnetic pulse, create different pulse sequences, and based on the duration of RF pulse. So in MR machine, it is a strong magnetic field. Once patient entered, we give radio frequency pulse, and then we receive the signal. Depending on the tissue, the signal intensity changes, and this gives different pulse sequence. So examples are T1 weighted, T2 weighted, flare, and diffusion. So there are lots of sequence depending on the clinical indication and depending on the scanner. But majority of the study, these are the basic sequences: T1, T2, flare, and diffusion. So whenever you see the MRI plate, try to see where is the T1 weighted images, where is T2 weighted images, where is flare or diffusion weighted images. So some important point to remember: MR is basically a slice of a part of the human body. So each slice has a thickness, and each slice has a voxel that is also called the volume element is present in this, usually 3 mm. On this spectroscopy, functional imaging. So now we will move. It is a test for visualizing the normal sharp boundary between gray and white matter. So on T1 weighted images, you can better differentiate gray matter, white matter, and CSF, and usually useful in evaluation of the CP angle system and pituitary fossa, because anterior posterior pituitary appears bright on the T1 weighted images. So as bone appear white matter appears lightly gray, and gray matter appears medium gray. Water, CSF, or air appear black. So in imaging plate, when you see the CSF black, then it is a T1 weighted images. So this is the T1 weighted images. You can see there is a gray matter underlying this white matter, and T1 is the only sequence that allows contrast enhancement with gadolinium. So contrast enhancement structure on T1 weighted images appear white. Now we will move to the next slide. Now the T2 weighted images, it is least distinct boundary between white and gray matter. So T2 is not useful for gray and white matter differentiation, but it is best useful for displaying pathology. So basically it is useful in demyelination, edema, and tumor infiltration. Gray matter appears gray, white matter appears dark gray, and CSF and water appear white. So this is the T2 weighted images. You can see the CSF in the ventricle as well as in the subarachnoid space appears bright or white in the signal intensity. The white matter appears light gray and the white matter appears dark gray, and overlying cortex or cortical gray matter appear light gray, and the vessels appears jet black. Similarly, the flow posteriorly sinuses appear jet black and bone appear hyper. Fluid attention inversion recovery, that is third sequence, that is called flare sequence. This is also a special type of the MRI scan in which E1 is inverted and added to the T2 weighted images. I think you should know that I think you should not go much detail about what is the physics of the flare images, but contrast between gray and white matter is double and normal CSF signal is suppressed. So basically, what is the role of flare in clinical practice? So it suppresses normal fluid like CSF, it suppresses CSF fluid, but whenever there is a edema, it gives bright signal intensity. So if you want to find out where is the exact pathology, the flare is the useful sequence. So special indication to detect sclerosis of hippocampus in temporal lobe epilepsy and to localize area of abnormal metabolism in degenerative neurological disorder. So any area in the brain which has edema, it gives brighter signal on flare images because it suppresses normal fluid, a CSF. So this is the flare images in which CSF appear darker or the black, but the edema area that we will see in the different pathological section appear brighter. Now the diffusion weighted images. What is the pathology of, what is the physiology or what is the physics of the diffusion weighted images? So normally water or intracellular, there is a free movement there is a movement of the water in intracellular space as well as extracellular space. So normally water moves freely across the membrane, so that permeability of the membrane or there is a movement of the water, it is called diffusion. So when there is a restriction or the alteration in the movement of the water, if there is a cell death or there is extracellular space edema, it gives altered diffusion of the water, and that gives signal intensity in specific set of the images, and it is called diffusion weighted images. What is the role of the diffusion weighted images? It sensitive to the speed of water diffusion. So visualize area of ischemic stroke in first tumor, so it is earliest to detect the ischemia. So MRI technique that enables the measurement of the restricted diffusion of water tissue. So this is the diffusion weighted images in which in this particular area there is a restricted movement of the water, that is called restriction of diffusion, and that is the first sign of the ischemia. So whenever there is a stroke, the first sequence to give indication of the stroke is diffusion weighted images. So whenever you suspect ischemic stroke or acute infarct, you must advise or you must see the diffusion weighted images. So principle of application in imaging. So water restriction or movement of the water is along some specific track, and depending on the length of the track of depending on the visualization of the track, we can evaluate the entire track, and this is the basic of diffusion tensor imaging. There are the few images or the few data or the few pictures of diffusion. The MRI scanner calculate the diffusion weightage of the brain tissue, and it produces 3-dimensional reconstruction based on the diffusion data, and this gives the 3 type of the track. How it is useful? When there is a particular some health track is involved, then it gives separate image or some abnormality in the track, some tumor that displays particular track, then we can better evaluate on the diffusion tensor imaging. And based on this track, in operative or in neurosurgery, they can predict the prognosis that this track is involved, this track is not involved, and this track has edema. So how the patient can progress after surgically. So now MRI, important point is, in MRI, magnet used in clinical practice range from 0.3 to 3 Tesla. So higher field strength produce image of higher resolution. So indication of MRI, to rule out organic cause of psychiatric illness, and when there is an abrupt change in mental status or new onset of memory loss or dementia. Advantage of this, it does not expose the patient to ionizing radiation. Demyelinating disease can be easily assessed on MRI, and better study of the posterior fossa structure. So disadvantage is it avoided in some patients if have a claustrophobia, and it does not pick any bony abnormality and difficulty in uncooperative patient that require a sedation. So IV contrast, when you should go for the IV contrast. So CT basically use iodine-based contrast because iodine is highly attenuating on X-ray beam. So it gives brighter image on the CT scan. MRI is gadolinium-based or gadolinium DTPA. Gadolinium is a paramagnetic metal that has an T1 relaxation of nearby water. So it gives a bright signal on the T1 weighted images. So tissue that get brighter with IV contrast is said to be enhanced. So enhancement reflects vascularity of the tissue as well as it reflects integrity of the blood-brain barrier. So when there is a breach in the blood-brain barrier, that gives enhancement or give brighter signal on post-contrast MRI. So now location of the some important brain structure by psychiatrist perspective. So the most important structure is amygdala, that is located that is better that I told this is the T1 weighted images. As I see that its CSF is bright or darker, it gives better visualization of gray and white matter. So where is amygdala located? You should look for the superior cut of the orbit, in which you see the medial temporal lobe, the most medial part of the temporal lobe. It is called amygdala, that visualize on coronal images like these and on sagittal images like this, that you can correspond by putting axial, coronal and sagittal images in a single cut. So this is amygdala. Now the hippocampus. Just posterior to amygdala, there is a bundle of the gray matter that is called hippocampus, that is visible on coronal images and linear structure on images. Now the in the CT scan, frontal horn of the lateral, first you have to identify the frontal horn of the lateral ventricle. Just lateral to it, there is a bundle of the gray matter that is called the caudate nucleus. Just lateral to the caudate nucleus, if you can perceive, there is a thin strip of white matter, thin strip of the white matter fiber that is called internal capsule. And lateral to the internal capsule, there is a lentiform nucleus that is further subdivided into globus pallidus and putamen. So putamen is the most lateral part that you can see on axial image like this. This is on the coronal and in the sagittal images. And just medial to the putamen, there is a globus pallidus that we see a little bit grayer structure. So MR spectroscopy. What is MR spectroscopy? The basic principle is similar to MRI except nuclei. So it permits study of many metabolic processes. Basically, MR spectroscopy is a quantitative assessment of the internal nuclei within this particular brain structure, and that give rise to the graphical presentation of the particular neuron. So now the structural imaging that we see, it gives you the anatomical position, anatomical landmark of the particular MR structure. Now we move further in recent advancement of neuroimaging. Now we are moving toward the chemical analysis or internal cellular analysis, and first of that is a MR spectroscopy. MR spectroscopy, we can see the neuronal activity or the metabolic activity within the neuron, and that give rise to different pulse, different chart based on the metabolic composition of the particular tissue or particular voxel. So normal, this is normal in which there is a high A and choline ratio. So depending on the alteration of the metabolism, metabolic structure or metabolic composition of the tissue, it gives peak of the choline, peak of the lipid and lactate. So depending on, we can analysis or we can evaluate what is internally going on within at the cellular level. And based on this, we can predict or we can diagnose certain disease or certain tumor. I will not go further detail of the MR spectroscopy, as Dr. Drushi will take care of whole functional imaging in the next lecture. So nuclei use and their MR spectroscopy and their use in the psychiatry, particularly water or hydrogen is used for decreased aspirate, mainly in the dementia and other neurological condition. Lithium used for the pharmacokinetic of the lithium, carbon for metabolic pathway, and F19 and P31. So significance of MR spectroscopy and psychiatry. So MR has revealed decreased Na concentration in temporal lobe and increased concentration of inositol in occipital lobe in with Alzheimer dementia. Decrease Na choline in temporal and frontal lobe, and also said brain lactate level during panic attack. So now functional MR, I will just go briefly. What is functional MRI? It is a subtype of MRI scan used for the new T2 or blood oxygen level dependent sequence, or it is called bold sequence, that is newly developed, like just like T1, T2 and FAIR images. It detects level of oxygenated hemoglobin in the blood. So it depending on the oxygenated hemoglobin level, it maps brain function, or it detects not the brain activity per se, but the blood flow. So advantage is, if possible, to study both cerebral anatomy and functional neurophysiology using single technique. So no radioactive exposure and used in the criminal psychiatry or federal investigation. Limitation has functional MRI assess neuronal activity indirectly by measuring the blood flow. This limits its resolution. Then I will just not go with the more in the functional imaging. In depression, in subgroup, you can see the different neuronal activity in schizophrenia. Now, just briefly, we'll go with the what is the SPECT, single photon emission CT. So, type of nuclear imaging that show how blood flow to tissue and organ. And it is basically a radioactivity tracer or radioactivity material analyzed by the CT scan, that is called the SPECT. So SPECT use compound label with single photon emitting isotope like iodine, technetium and xenon. So principle is, when we inject radio label material within the patient, it emits gamma ray and it is detected by the scanner or the CT scan, and it translates into 2D image, and this image get translated into the 3D image, where it is used to detect regional cerebral blood flow. Technetium is most commonly used for deeper structure, a xenon for the superficial structure. Now, the PET. PET basically, it is a radioactive isotope. It is FDG. So basically, it is a radioisotope, or it is a labeled glucose that we inject into the patient, and depending on the metabolism, it consumes the glucose, and how the glucose consumption is distributed across the body, that we can evaluate by the CT scanner, and that is also called the PET. So PET most commonly used in the oncoimaging, and now in conjugation with the MRI, we can use into the functional neuroimaging. So that I will not go more with the SPECT on FACT. So now we will move to the imaging in specific psychiatric disorder. So now in later part of the lecture, what is the role of the structural neuroimaging in case of the dementia? Then we will discuss in the Alzheimer disease, frontotemporal dementia, Lewy body dementia, and vascular dementia, or dementia associated with Parkinsonism, or it is also called the multi-system atrophy P. Then also we will discuss normal pressure hydrocephalus, obsessive compulsive disorder, depression and bipolar mood disorder. Then we will see the structural neuroimaging changes in anxiety disorder, post-traumatic stress disorder, ADHD, autism, and some basic toxication. So dementia, the purpose of structural neuroimaging or purpose of the neuroimaging is to diagnose the cause, monitor the disease progression, and staging of the disease. So first we will go, the most common is a Alzheimer disease. So in Alzheimer disease, the typical dilatation of the lateral ventricle, of the cortical circuit, particularly in the perisylvian area as well as in the posterior fossa. Specific brain region like hippocampus and medial temporal also shows atrophy. On MRI, this is normal MR images. On Alzheimer's disease, you can see there is a widening of the CSF sulci. And if you look closely, there is a diffuse atrophy of the hippocampal structure. So volumetric MRI reveal shrinkage of the particularly the medial temporal lobe and hippocampus. So this is the T2-weighted images in which you can see there is a deepening of the cerebral sulci and widening of the CSF space and widening of the ventricle. If we see particularly on the medial temporal lobe, you can better appreciate there is a widening of the choroid plexus or the temporal horn of the lateral ventricle. That is indirect sign of the atrophy of the hippocampus. So functional imaging, early study using PET or SPECT reveal characteristic pattern of hypometabolism in posterior parietal lobe. And MR spectroscopy shows decreased concentration of Na in the temporal lobe and increased concentration of inositol in the occipital lobe. So this is the image of the PET in which there is a decreased metabolism in a particular area in patient of the Alzheimer's disease. Now, the next form of dementia, that is called frontotemporal dementia. The name itself suggests that it is a frontal and temporal dementia. So more or less the frontal lobe involved and temporal lobe involvement, which relatively sparing of the posterior parietal and occipital lobe. In this type of the dementia, there is a severe localized atrophy of the frontal and temporal lobe. It is also called knife blade atrophy. So in sagittal normal patient, you can see the symmetry or there is a normal sulci on the frontal lobe, frontoparietal lobe. But in temporal dementia, you can see there is a sharp atrophy of the frontal lobe with prominent sulci and relatively sparing of the posterior and occipital lobe. This is the classical case of the frontotemporal dementia. Similarly, on the axial imaging, there is a severe sharply localized atrophy of medial temporal lobe, or it is also called the knife blade atrophy. So on functional imaging, so there is a hypoperfusion including temporal lobe. So now the third set of dementia, it is called Lewy body dementia. So no MRI feature have been identified characterize Lewy body dementia. So absence of significant medial temporal lobe lobe atrophy in elderly dementiated patients suggests Lewy body dementia rather than Alzheimer's disease. So sometimes PET or SPECT reveals reduced occipital function with generalized reduction of the cortical activity. Now the vascular dementia. So dementia due to chronic cerebrovascular disease, patient with the long-standing hypertension, long-standing amyloid angiopathy, or long-standing diabetes. It forms multiple small vessel ischemic disease and then leads to the vascular dementia. It is further classified into multi-infarct dementia, subcortical vascular dementia, or it is also called Binswanger disease or cerebral amyloid angiopathy, particularly in the renal impairment. So in vascular dementia, you can see on T2-weighted images, there are multiple small hyper-intense ischemic areas. This is multiple hyper-intense small vessels. Basically, basal ganglia and thalami are supplied by the end artery. So any disease that affects the end artery, like long-standing hypertension, long-standing diabetes, leads to repeated ischemia of that particular region, and that develop multiple infarct of variable sizes, and that leads to as well as area of gliosis. When it develops in there is a particular space that leads to the multi-infarct dementia, or it is also called the vascular dementia. So in respect of vascular finding, there is a hypoperfusion in this particular perfusion in particular basal ganglia or deep nuclei. So now there is a and most important sequence is the sequence. It gives reduced signal in see images. There is hypo intensity typical pattern. It is a typical pattern is particular of MMT.
Yeah, please wait. Probably there might be some network issue at sir's end.
Everyone should come outside. Outside. So you are ready.
Yeah, Sndeep sir, please share your. Mr. Charan Kumar, please mute yourself. Everyone else, please mute yourself.
Okay. So now we'll move ahead with the normal pressure hydrocephalus. It is basically a triad of the dementia, gait disturbance, and urinary incontinence. So sometimes dementia patient associated with the gait disturbance and urinary incontinence, usually after 60 years of the age. There are two types of the theory, in which first there is an impaired extraventricular CSF absorption due to prior subarachnoid bleed or meningitis, and it leads to decreased white matter tensile strength due to deep white matter infarction. So there is a particular MRI feature in which we can assess the normal pressure hydrocephalus. What is the MRI feature? In which the ventricular enlargement is out of proportion to the cerebral atrophy. When there is an atrophy occur, it also gives proportionally atrophy of the cords sulci with dilatation of the ventricle. But once you see that there is an in-proportional dilatation of the ventricle compared to the cerebral cortex or cerebral sulci, then it leads to the diagnosis of the normal pressure hydrocephalus. There is a two objective measurement. First is the Evans index. How we can measure? We can measure the length of the frontal horn of the lateral ventricle at the same level. Inner tail of the skull length is measured, and this is divided and it is gives Evans index. Normally it should be more than 0.3. When it is less than 0.3 or particularly less than 0.02, then it gives diagnosis of the ventriculomegaly, or if ventriculomegaly is associated with the clinical feature, then you can give diagnosis of the normal pressure hydrocephalus. Similarly, the ventriculomegaly is also assessed by the ventricular angle. Ventricular angle, how we can measure? We can measure at the level of the posterior commissure, and if angle is less than 90 degree or less than particularly 90 degree, then it leads to the diagnosis of the normal pressure hydrocephalus. So primary MRI finding is ventricular enlargement out of proportion to the sulcal atrophy, prominent periventricular hyperintensity, prominent flow void in the aqueduct and third ventricle, so-called jet sign. Is how it looks. It present as a dark aqueduct and third ventricle on T2 weighted images, and thinning and elevation of the corpus callosum on sagittal images. So now we move to the imaging in obsessive compulsive disorder or OCD. So the structural finding is bilateral smaller caudate nucleus, so significantly more cerebral gray matter and less white matter volume than normal control. In OCD, there is a decreased volume of left orbital frontal cortex and abnormality in the length of the corpus callosum. It is also associated sometimes in abnormality in pituitary volume. So large anterior cingulate volume, increased OCD symptom severity, but not the duration of the illness. So in which there is a decreased gray matter region in with obsessive compulsive disorder. On MR spectroscopy, it gives particularly greater glutaminergic concentration in the caudate. So if we analyze the chemical analysis by MR spectroscopy, particularly in the caudate nucleus, so if you suspect the obsessive compulsive disorder, then we can basically do MR spectroscopy giving voxels on the caudate nucleus, and it gives glutaminergic concentration in the caudate. So it gives little bit glutaminergic peak in caudate. So it leads to the, or it stamp out the diagnosis of the obsessive compulsive disorder. So now we move to the imaging in depression and bipolar disorder. So what is the role of CT and MR in depression? So in depression, smaller volume of frontal cortex, cerebellum, caudate and putamen, particularly basal ganglia. So ventricular enlargement, cortical atrophy, and sulcal widening have also been reported. The most consistent abnormality observed in depression is increased frequency of abnormal hyperintensity in subcortical region, including periventricular region, basal ganglia, and thalamus. So in patient of depression, particularly periventricular region, basal ganglia, and thalamus involved, and some depressed patients also have specifically reduced hippocampal or caudate nuclei volume focal defect. So focal area of atrophy associated with increased illness severity, bipolarity, and increased cortisol level. So what is the role of the functional MRI? So bilateral anterior cingulate cortex, right amygdala, smaller in size, and inactivation of left prefrontal cortex in depressed patient. So this is the structural or functional mapping in patient with the bipolar mood disorder, or basically patient with the depression. So now we will move to the CT and MR in schizophrenia. In schizophrenia, there is enlargement of lateral and third ventricle, may be static or progressive. Frontal lobe abnormality, particularly prefrontal gray matter and orbitofrontal region involved. Parietal lobe abnormality, particularly inferior parietal lobule, which includes supramarginal and angular gyri. All these structure abnormality may be static or progressive. So positive symptoms lead to decreased volume of superior temporal gyri, and negative symptoms has enlarged ventricle and decreased volume of the medial temporal lobe. So this is the normal medial temporal lobe on chronic schizophrenia. On coronal images, you can see there is an increased CSF in lateral amygdala hippocomplex hippocampal area, and leads to the decreased volume of the amygdala. So in functional imaging, there is a hypoactivity in the frontal lobe, but I will not go much into the detail, and Dr. Drushi will take care of this. So now we will move to the imaging in anxiety disorder. So anxiety, on structural imaging, there is increased size of the ventricle, abnormalities in right hemisphere but not in the left hemisphere. These findings suggest that some type of cerebral asymmetry may be more important in development of the anxiety disorder. So particularly anxiety disorder, there is a asymmetry between right and left cerebral hemisphere. And on functional imaging, abnormality in the frontal cortex, occipital and temporal area in patient with the anxiety disorder. On MR spectroscopy, as I discussed earlier, it gives brain lactate concentration elevated during panic attack without provocative infusion in panic disorder patient. So now we'll move to the imaging in post-traumatic stress disorder. It gives reduced left and right hippocampal volume. So volume reduction were associated with the severity of complex disorder. Smaller hippocampal volume is not a risk factor for development of the PTSD. Functional imaging in PTSD, I will just keep this. So now we will move to the imaging in the ADHD. It shows no consistent finding, but sometimes increased cortical gray and white matter volume from 5 years of age with peak at the 12 years age. So early onset ADHD associated with the smaller total volume brain in 4% cases, and decrease in the volume of particularly posterior inferior cerebellar vermis. That is the region that involved in the attention processes. So there is a more role of functional imaging in patient of the ADHD than in the structural imaging. So in functional imaging, we can see there is a little or less activity in the frontal cortex. So PET scan there is a higher metabolism in normal no ADHD. In blue-green shows lower glucose metabolism area. So in autism, significant decrease of gray matter concentration in superior temporal sulcus bilaterally in area which is critically for perception of the key social stimuli. So in autism, superior temporal sulcus is involved. So also a decrease of white matter concentration in right temporal pole and in cerebellum compared to normal children. So brain enlargement has been considered as a positive biomarker for autistic disorder. So this is the typical disorder. On 31 month, there is a brain volume. And in autism, early onset, similarly, it shows little bit higher brain volume. So functional imaging, bilateral hypoperfusion of the temporal lobe on autistic child in addition. Activation abnormality may be observed in the temporal lobe and amygdala, and increase in the visual cortex activity also reported. So now we'll move to the alcohol dependence. So alcohol patients tend to have large ventricle and wider cerebral sulci and fissure than control. On CT scan, there is cortical atrophy also reported. Abstinent patient may show reduction in ventricular size. On MRI, pronounced and elastic reduction in the cortex volume leads to disruption of the neurodevelopment of the process. DTI shows disruption in the integrity of the white matter tract. Volumetric changes are also severe in patients with the Wernicke-Korsakoff syndrome. On MR spectroscopy, during acute withdrawal, cortical GABA level normal. With recovery from alcohol dependence, cortical GABA level appears to decline and significantly below seen in normal healthy individuals. So other substance disorder and cocaine, the more or less the structural changes are less common in this cocaine or opiate dependence. They more shows the functional neuroimaging changes, just like tobacco smoking. So now in some type of toxication like methanol toxication, particularly after suicidal or accidental ingestion, in which this is the flare images in which bilateral symmetrical involvement of the putamen. So now you can, this is the flare images as we previously mentioned. This normal CSF signal appears darker, and when there is a pathology, it gives a bright signal. So this is particular bright signal in particular in the caudate and putamen. So this is the typical case of the methanol toxicity. Similarly, carbon monoxide toxicity, in which it is also called gas geyser syndrome. So very particular history, patient get unconscious or altered sensorium in particularly bathroom or in bathing, and in which there is a caudate nucleus and globus pallidus involved. So in summary, neuroimaging can be structural and functional. Functional imaging is more useful than structural imaging in neuropsychiatry, and it is a newly developed modality or newly developed sequences. So neuroimaging in psychiatry is presently mainly rule out neurological cause and evaluation of the dementia. Still various study and their findings and newer development hold promise for future of the neuroimaging in psychiatry diagnosis and management. Thank you very much for your presence listening.
Thank you so much, Dr. Sndeep Mevada. It was wonderful to see so many all disorders separately with very lucid explanation. Thank you so much.
Thank you, sir.
Pleasure to hear. I think I would hand over to Dr. Pankaj Kumar, sir. Please, sir. Thank you, sir.
Thank you, Deepak Timari, sir. And thank you, Dr. Mevada, for giving such a comprehensive presentation, trying to cover most of the important disorders and common findings. So now, without wasting much time, I'd like to invite the chairpersons for the another session on functional imaging in the psychiatry. And the chairperson is Dr. Arun Marwale, sir, and he's the professor of psychiatry, MGM Medical College, Aurangabad, and he is also the immediate past president of IPS West Zone branch, has served on the many many of the task force or sub-specialty of IPS earlier, especially his contribution as a IPS Social Security Scheme Task Force member has been very, very important and well recognized by all the people. So, with that brief introduction, I would like to invite Dr. Arun Marware sir to start the next session. Over to you, sir.
Thank you so much, Dr. Pankaj Kumar, sir. Am I audible?
Yes,
Yes,
sir.
Yeah. So, at the outset, I thank the biological subcommittee of IPS, Chairperson Pankaj Kumar, Vice Chair Manik Bise, and other members. So also the office bearers, Dr. Vinay Kumar, Arvind Brahma, Ali. Just now we have listened to Dr. Sndeep Mevada, who has given the illustrated account of structural imaging. Of course, structural imaging is very important for us in organic psychiatry. But what is most important is functional imaging. And none other than Dr. Drushi Patel will be talking on that. So I would like to give a brief introduction of Dr. Drushi Patel. She is consultant radiologist at Gujarat Imaging Center. Her academic qualification is MD Radiology, and she has visiting fellowship in MSK and body imaging at Duke University. Years of experience is almost 13 plus years. She has many awards and achievements to her credit. Some I will just comment on. So twice come Laude awardee for the educational exhibit at RSNA 2014 and 2019. Then she's co-authored a book titled Cornerstones of Radiology and Diagnostic, Basics and Beyond with Dr. Isha Rajput. She authored a chapter in a book titled The Illustrative Magnetic Resonance Imaging of the Chondral and Osteochondral Lesions. That was edited by Dr. D.R. Goyal. She authored a couple of chapters in IRIA textbook on cartilage imaging. So probably that is the specialization that she has. Actually engaged in controlling DNB academic activities at Postgraduate Institute of Radiology and Imaging at Gujarat Imaging Center, Ahmedabad. With this brief introduction of Dr. Drushi, I invite her for her deliberation. Thank you so much.
Thank you, Dr. Marwale, sir, for having me. At the outset, I would also like to thank Dr. Manik Bise and Indian Psychiatry Society for this kind invite. So my topic is on functional imaging in neuropsychiatric disorders. Now, Sndeep has largely covered the functional imaging part. It is going to be partly a repetition, but I'm sure with these advances, if somebody is listening to them for the first time, it's not easy to comprehend all these newer techniques at a go. So neuropsychiatric diseases, the disorders of memory, motion, cognition, they are challenging to assess by neuroimaging, unlike the neuropathological conditions. And these newer modalities that we have, functional neuroimaging modalities, they are opening new avenues in understanding these illnesses. So there are multiple modalities, a lot of them that Sndeep has touched upon. So what I'm going to do in my lecture is, this lecture is just going to touch upon these newer modalities. It's going to be long enough just to cover them and just short enough to create an eagerness and awareness to know more and where you can start applying. The applications in neuropsychiatry.
Ma'am,
Yes. Yes.
Your presentation is not visible, man. Hello.
I have started sharing. Should I?
Restart. Yeah, now it is
Yes,
visible.
now.
Yes.
Yes.
Okay.
Thanks.
So we've seen that. We've seen there are a lot of modalities. So Sndeep has touched upon almost all of them. I'm going to focus on the functional MR, functional part. So the session is going to be long enough to, cover these topics. Am I properly audible?
Yeah, you're audible, madam. Someone else is repeatedly keeping. Mr. Charan Kumar, please mute yourself.
Yeah. All right. So we'll touch upon these modalities. We're going to keep it simple. There are a lot of, besides the usual diffusion and the susceptibility weighted images and the contrast imaging, there are MR volumetries, functional MR, DTI, PET MRI, MR perfusion, spectroscopy, and the new 3D APT imaging, which are used for evaluation of various neurological pathologies. I'm going to focus on these three. What I'm going to do is I'm going to talk about their principles, how to read or interpret them, what are the neuro applications, and what are the neuropsychiatric applications. Now, higher strength magnet, that is a 3T magnet, is better, where especially for these advanced neuroimaging like functional MR and DTIs, because of the better signal to noise ratios. So coming to fMRI. fMRI, as you know, the different parts of the brain are associated with different functions. So the prefrontal cortex being associated with personality and behavior, the premotor and the motor cortex for voluntary movement, sensory, somatosensory cortex are for somatic sensations and proprioception. There is the auditory visual association areas, that is in the occipital lobe. And then there is Broca's and the Wernicke's area, which are associated with language and speech. So functional MRI has capability to look at these areas, and by mapping these areas by doing those particular activities. So the basic concept of functional MR is that we map the function by evaluating the MR signal. Functional MR, it detects these subtle alterations in the blood flow in response to stimuli or actions or tasks. And that is what is picked up. This MR signal is picked up and evaluated and seen on a map. So in clinical practice, more commonly, what we do and use these functional MR is to evaluate the motor function, as in like wiggling the toes or finger tapping, to evaluate voluntary movements in the motor cortex. Or we do speech evaluation, with evaluation of the Broca's and the Wernicke's area by giving speech-related tasks. It is typically helpful in pre-surgical patients where there is a particular lesion, and we in these expected areas, and our aim is to see whether to prognosticate rather where the actual functional areas are, and whether it can cause difficulty or can compromise these areas post surgery or post biopsy. Research, it has a role in psychiatry. It is aimed at elucidating these novel neural networks. So psychiatric disorders, since it tends to involve impaired neuronal activity more than the disrupted gross anatomy, so that physiology becomes more important than the anatomic imaging. And Sndeep has already, wherever there has been a structural abnormality, there has been enough research to identify the functional part of it and its applications in psychiatry. So functional MRI, it basically measures the bold contrast. What is bold? Bold is blood oxygenation level dependent contrast. So the person or the patient is asked to do alternating activity and rest. And that is when the bold signal is evaluated. So at basal level, when the patient is at rest or not doing any activity, there is normal flow through the vessels. And the basal CBV values are there. So there will be a normal MR signal. When the patient is asked to do a particular activity, the area of the brain that is responsible for that particular activity will become activated. There will be an increased flow in that region, and hence there will be an increased MR signal. This is very simply put. What happens is, whenever a particular task is done, in that particular area which is responsible for that task, there is increased blood flow, and hence there is increased oxygen consumption. So there is increase in the oxyhemoglobin that enters in that particular area. Deoxyhemoglobin is reduced. So this deoxyhemoglobin is the marker which is picked up because this deoxyhemoglobin, it causes decreased magnetic susceptibility, and that is what is picked up as an MR signal. And that is the basis of bold imaging. So this is a particular setup, how it is done. At our center, we have a 3 Tesla magnet. What we evaluate is just the motor activity, the hand and the foot activities that are evaluated, especially for lesions which are there in the motor cortex. And secondly, we do speech evaluation, that is usually speech and language evaluation. So both of these just require an audio command. So the patient is given a set of earphones, and through the computer an audio command is given, and the patient registers the response and or does the activity, which is then mapped by the MR signal. Usually the visual apparatus is required if we need to map the visual cortex, and that requires a special apparatus where the patient can visualize certain images on the screen, and the signals are evaluated on the MR image. So what happens is that during activity and during resting phase, there is bold signal or MR signal that is picked up. What is subtracted, that gives you the functional MR map. That functional MR map, it is placed on the structural or the anatomic image. Overlay is done, so that we understand that which exactly anatomical area is that functional bright signal being seen, and that's how we evaluate. So this is the neuro application. Say there is one lesion that is there in the motor cortex, or that this is in the perirolandic region. There is a lesion. When an fMRI for a left hand finger tapping is done, since we do it for both the hands, both the foot, but when a lesion is in the right hemisphere, what is important is the left hand or foot activities which are important. Okay, so the contralateral side here, I have demonstrated the left hand finger tapping activity. You can see that there are these bold signal which is light up. These are the functional areas which are responsible when the patient taps his finger. And you can see that these areas are away from the the lesion that is seen on contrast images, suggesting that there is a significant margin that is available, and also there is an unobscured trajectory that can be made available for the approach to this lesion. So this is what information a functional MR gives in neuropathological conditions. In cases of epilepsy, as in here, there is this is an inversion recovery sequence on a 3T MR, which shows very beautifully the hippocampus. If you compare it to the contralateral side, there is atrophic changes. On the FLAIR images, there is increased signal suggesting that there is neuronal gliosis. There is a method that is known as T2 relaxometry, where the relaxometric values are increased as compared to the contralateral side. So on structural imaging, this is a case of mesial temporal sclerosis. Now, this patient was to undergo left-sided temporal lobectomy and had come for evaluation of the speech area, that is the Broca's and Wernicke's area. So a passive listening paradigm was performed, wherein alternating speech commands are given to the patient in active phase in a vernaculum that he can understand. So if he understands Gujarati, during the active phase, it is the Gujarati command that is given, and during the resting phase, command which in a language which he cannot understand, say Tamil or anything which he cannot comprehend a word about, is given during the resting phase. A typical passive listening paradigm is performed. Now, if you look at this fMRI images, there is a lot of activity that you see in the right hemisphere. So this right hemisphere means that this patient is a right hemisphere dominant person. Fortunately, since he was to undergo a left temporal lobectomy, it is safe that it is a right hemispheric dominance. Secondly, if you can see that whatever on the left side, the activity is seen in the temporal or the perisylvian frontal regions is away from the region of the hippocampus, that is this hippocampus and amygdala, where the site it was going to be resected. So fortunately, what was suggested from this functional MR is that it is unlikely to cause any damage to his speech when temporal lobectomy is done for this particular patient. So this is what we do in the neuropathological part. Now it has applications in neuropsychiatry as well. It is of use in obsessive compulsive disorder. It is observed that when a patient is given a provocative task, which is tailored for each particular patient for which he has an OCD. Say a patient has an OCD for hand washing or touching dirt, a similar provocative task is given to the patient or he is exposed to, and the fMRI signals are evaluated. Then you will see that there is activation in certain areas. These certain areas usually for OCD are orbital and frontal cortex, caudate nucleus, thalamus, anterior cingulate cortex. And when an fMR is performed following therapy or treatment for an OCD, following medication or a behavioral therapy, there has been studies that this fMR signal has reduced after therapy. So it has a use in monitoring the therapeutic response in OCDs. Now, a word about default mode network. It's not that our brain is not functioning or is not having areas during resting phase. So what has been found with fMR and which has been observed is that there are default mode networks. There are certain areas in the brain which become active during passive tasks, meaning during periods of rest, or when your mind is wandering, or when you're not paying attention, or when you are not given any particular task to perform, then there are certain areas that are light up, and these form a part of the default mode network. It has been identified that largely it is the posterior cingulate cortex or the medial prefrontal cortex and the inferior parietal lobule, which are the areas of default mode network. So in schizophrenia, as you know, it's a chronic mental disorder, and there is a role in schizophrenia for this. So let's see in a normal subject. When the subject is at rest, there will be in areas of activity in the medial prefrontal cortex and the posterior cingulate gyrus or the inferior parietal lobule. Now, when the person is given some task, say one task, second task, third task, you look at the consecutive images, then depending upon the area where what the task is given, obviously that area is going to light up. Here, in this study, it was the memory task that was given, and then the areas which are activated during the resting phase, they gradually reduce. Okay, so there is an inverse relationship between the default mode network and the operative memory task complexity. What was found in schizophrenia is that this default system is both hyperactive and it is hyperconnected during rest, and it will remain so even when these memory tasks are performed. So the less the suppression and greater the connectivity, worse will they perform. So if you look at the similar experiment in a schizophrenic patient, there will be, see, this was a 19-year-old with a long-standing clinical diagnosis and family history of schizophrenia. He had certain areas, that is in the posterior cingulate gyrus, parietal lobule, and the medial prefrontal cortex, which were lighting up on fMR in a resting phase. Even because of the hyperactivity and hyperconnected networks, even on giving tasks, these areas, they did not reduce, okay, when this activity was given. Secondly, the default mode network has a role also in Alzheimer's disease. Now, in Alzheimer's disease, we know that there is atrophy and amyloid deposition, which occur typically in the region of posterior cortical regions. That is why even on structural imaging, it is these areas, that is the posterior parietal regions, that show atrophic changes in advanced stages. But functional MR can be helpful, especially for identifying early changes, since it is the same area where the default mode network is that is involved. It is found that in Alzheimer's disease, there will be decreased activation in these areas as well. So it is usually the medial temporal lobe and the posterior temporoparietal regions that show decreased activation in Alzheimer's patients. Also, there are certain areas which are associated with grief. These neural regulatory circuits in grief are in the anterior cingulate cortex, or in the amygdala, or dorsolateral prefrontal cortex. So there was this experiment where they did for grieving subjects, and when they were presented with information or task wherein they were exposed to disease-related material, or there was a control stimuli, and it was studied, that was found that it were these areas which got lit up on functional MR. So what was concluded from this is that when these grieving patients with intrusive symptoms, they are more likely to progress to complicated grief and require therapy when they have higher, stronger fMR signals. Coming to the next modality, that is the diffusion tensor imaging. So what is diffuser tensor imaging or DTI? It is a technique used to demonstrate orientation of the white matter tracts. It can assess its structural integrity as well as quantify the anisotropy. So I'll tell you what is anisotropy, but what are the applications? In neurology, which we commonly do is during pre-surgical planning. Say there is a lesion and we want to see how it is affecting these white matter tracts, then they come for DTI. Secondly, for post-operative follow-up in patients with intracranial lesions, that is for evaluation of the the effect on these tracts, and in psychiatric disorders. So the basic concept of diffusion tensor imaging is that diffusion is anisotropic, meaning it is directionally dependent. Say in white matter tracts, you know that there are axonal membranes and myelin sheaths. These axonal membranes and myelin sheaths, they act as a barrier to the motion of water molecules. As mentioned before, the diffusion, it reflects the cellular function or the motion of water molecules. So what happens is that these axons and myelin sheaths, they are They act as barrier to the motion of water molecules and in directions that are not parallel to their own directions. So the direction of maximum diffusivity, it is in the same direction in which the white matter tracks are oriented. On the basis of this, there is a mathematical model that is created, and that is how the DTI tracks are mapped out with MR. I cannot go into that extensive physics of DTI, but you understand that the direction in which the maximum diffusivity is the same direction in which the white matter tracks are. And since we can measure this directional diffusivity, we can map out the tracks also. So when we perform a DTI, what we get is an image like this, wherein we see the tracks. Now we coincide or co-register these DTI map onto the anatomic imaging or the basic T1, T2 weighted images that we have obtained, so as to identify the regions also along with the track. And then this information is also post-processed, so that with fiber tractography, we can track out each track and give color coding to it. So there is, we measure the fractional anisotropy, and each of these tracks are color coded. Usually the red is for right to left directed tracks, green is for anterior to posterior, and blue is from superior to inferior. So based on this, we can identify the association fibers which connect the two cortical areas. We can identify the commissural fibers, that is the one which goes from left to right. We can identify the projection fibers which go from above to below. And we can identify the tracks in the brainstem. So this is how it takes into consideration the fractional anisotropy and the white matter tracks, which are post-processed, and we can obtain relevant images. So in neurology, the role of this is that we can identify various patterns, what is happening to these tracks. Say there is one lesion, one particular lesion on structural imaging, then we can identify whether the tracks are deviated, or as in this case where the tracks are edematous and appear swollen as compared to the contralateral side, or they are infiltrated, or the fourth pattern is where they are completely destroyed in that particular region. So we can identify this pattern and what that lesion is doing to these tracks and help in prognostication of that particular disease. Its role in neuropsychiatry is that in schizophrenia, it has been found that the fractional anisotropy is reduced, especially in the region of cingulate gyrus. So as compared to the controls, there is decreased number of fibers in this region. Also, there has been studies where there is a decrease in the fractional anisotropy, and hence the white matter tracks, especially in left frontal and temporal deep white matter, with involvement of inferior fronto-occipital and uncinate fasciculus. Bipolar disorders, these are chronic mental illnesses characterized by severe disruptions in mood and cognition. I'm taking the FMR part also here. So in FMR, it has been found that there are areas of activation in the region of amygdala in bipolar mood disorders. And on DTI, it has been found that there are lower fractional anisotropy, and hence the tracks in the corpus callosum and cortical and thalamic association fibers that are involved in bipolar disorders. In major depressive disorders, it has been found that fractional anisotropy is measured in cingulate hippocampus, in cingulate gyrus, and in hippocampus bundle, fornix, striata terminalis, and the uncinate fasciculus, and evaluated. In ADHD children, it has been found that these values are reduced, especially in the circuits that travel from superior to inferior, that is cortico-pontocerebellar circuits, as well as into the frontocerebellar circuits that show reduced fractional anisotropy. So all this information, I hope it has not been confusing or you feel lost. Next that we move towards is the molecular imaging, which is a little simpler. Molecular imaging meaning PET-CT or the SPECT imaging, wherein first we talk about PET-CT, which is a measure of metabolism using radioactive glucose. So what we do is there is a cyclotron machine wherein there is radioactive material, here in this case 18 fluorine that is obtained, which is tagged with the glucose molecule. So it is radioactive material and FDG tagged together that is injected into the patient, and then there is a PET scanner which scans the amount of radiation that is emitted from the patient due to the radioactive material, which is mapped. And that is how we get the PET-CT images. So the basis of this is that the radiation tagged glucose, that is the FDG, it competes with the normal glucose in the system and to enter into the mitochondria. So when it enters into the mitochondria, just like the glucose, it will also undergo phosphorylation, but it cannot go further into the cycle, and so it will get trapped within the mitochondria and into the cell. And then this trapped glucose in the cell is going to emit the radiation, stay there till it decays, and that is what is mapped by the PET scanner. Okay, so the PET-CT or FDG PET-CT, it is a measure of the glucose metabolism. So what does the typical scanner look like? This is how a typical scanner looks like, wherein there is one circular gantry of CT scan, and just behind back to back there is a gantry of the PET-CT. So the CT scan, it provides the structural cross-sectional images, and the PET, behind that, the PET scanner, it will pick up the gamma radiation. The PET detectors will pick up the gamma radiations that are entrapped in the cells of the patient or wherever they have concentrated, depending upon the pathologies, which will be, that will give a PET image. So that is how a PET and a CT image is generated. Now with PET MR, there can be a PET MR machine also similar to this, wherein there is a PET scanner, and back to back there is an MRI machine. Or there can be a software-based fusion, wherein PET images are obtained in the PET-CT scanner and MRI images are obtained in the MR scanner, and then the software will do its job of fusing these images. So what we do at our place is we do have both the scanners, the PET, PET-CT, and we do a software-based fusion to obtain PET MRI images to evaluate the glucose metabolism. And a Cortex ID map is generated, which is again a software-based analysis to look at how the glucose metabolism is. So this is how a typical hypometabolic area looks like in relation to the adjacent normal metabolism. This is a case of a right MTS, and so the temporal lobe had hypometabolism. Whereas this is how a typical hypermetabolism will look like. It has a role in picking up lesions like malignancies. So here there is some structural lesion. But if you look at this large structural lesion, which is a post-radiotherapy case of a glioma, there is a small area which is showing hypermetabolism, which is suggesting that that is the recurrent lesion, and rest everything else is radiotherapy-associated changes. So this is how a hypermetabolism looks like. So PET-MR brain has applications in epilepsy, dementia, neurodegenerative disorders, movement disorders, psychiatric disorders, and along with brain tumors. So this is a typical 32-year-old with a seizure complaint, and you can see that there is a reduced right-sided hippocampal volume showing increased signal on FLAIR images. This is a right-sided MTS, and the PET-MR fusion images showing the more significant hypometabolism in the right temporal lobe. So this is right mesial temporal sclerosis. Another case of a 7-year-old boy who had intractable epilepsy. The MR was normal, came for an PET MRI, And if you look at the PET MRI, there is this area which is showing hypometabolism. So this is the parietal region which is showing hypometabolism. This suggests this is extratemporal non-lesional epilepsy, and PET MRI can identify the metabolic abnormality and a cause for or the site, localize the site for the epilepsy. A 72-year-old man with history of slowly progressive cognitive impairment. If you see the structural images, there is this sulcal prominence. So these are all atrophic changes that are there. And they appear more or less mildly generalized atrophic changes are there. But if you look at the PET images and the PET MR images, you can see that there is a little hypometabolism in the parietal lobes with preserved metabolism in the frontal lobes. This is a case of early Alzheimer's disease, wherein the posterior parietal lobes are affected first. Another 80-year-old with progressive memory impairment. Here you can see that there are again moderate to severe atrophic changes on the structural MR. But if you look at the PET MR images, there is more or less generalized hypometabolism that is seen in fronto-temporo-parietal all lobes, and this is a case of advanced Alzheimer's disease.
एक incoming call आला.
A 60-year-old female with history of progressive decreased fluency with hesitancy of speech. You can see that there is atrophic changes that are more so in the frontal lobes on structural imaging. On PET MR images, you can see that there is the bilateral frontal as well as the anterior temporal lobes that are showing hypometabolism. This is a case of frontotemporal dementia. A 70-year-old with on treatment for Parkinsonism having altered behavior and visual hallucinations now. If you can see that there are generalized atrophic changes, no specific disproportionate atrophy, but a PET MR was performed and it shows hypometabolism in the occipital lobes, and this is a case of dementia with Lewy bodies. A 57-year-old with rapidly progressive dementia and personality change. If you look at these are the flare images and this is the diffusion weighted images. Now there are subtle cortical hyperintensities in flare, diffusion restrictions on diffusion weighted images. And if you look at the PET images show generalized hypometabolism. So there is a disproportionate metabolic abnormality as compared to the structural MR brain findings, and these are typical findings that we see in Creutzfeldt-Jakob disease. A case of cerebellar syndrome having ataxia since 2016, MR showed diffuse disproportionate cerebellar atrophic changes. PET MR showed diffuse hypometabolism in cerebellar hemispheres, and this patient was being treated as post-infectious viral cereballitis. IV immunoglobulins were administered and residual ataxia was there. All the paraneoplastic panel was negative, but the anti-nuclear antibody was positive and anti-TPO antibody was positive. So this is findings that we see in a paraneoplastic cerebellar degeneration. A 25-year-old female presented with convulsion and memory loss. On structural MR imaging, you can see that there is hyperintensity in the region of the medial temporal lobe, in the region of amygdala and hippocampus. On PET MR, there is increased metabolic activity and tracer uptake that is seen in this region. These are findings of non-paraneoplastic limbic encephalitis. In a case of autism, these are the findings. There are very subtle findings that you see, and there are subtle hypometabolism that is seen in especially the temporal cortex and the posterior parietal that is not actually shown here. It is the temporal here that is very well shown in these images. So in the temporal cortex, there is subtle hypometabolism is there. This is a case of, this is the findings in autistic spectrum disorder. SPECT, just a repetition, and I'm not going to go in the details of this. So SPECT is basically requires a gamma camera. It's a nuclear medicine technique which uses gamma rays, wherein a marker or radioisotope like a technetium tagged to a specific ligand is that is a radioligand is used, and it is injected into the patient. So on IV administration of this gamma emitting radioisotope, there is this radioligand, it goes and binds to that specific place of interest in the body, and then it starts sending that gamma rays which escape the patient, and then these gamma rays that are catched by the gamma camera detectors, and that will compute into an image. So this gamma camera, it has these two detectors which will rotate round and round around the patient and catch all those gamma rays, and the total scan time is usually 15 to 20 minutes, and that is how a SPECT image is obtained. So emissions from that particular radionuclide indicate the amount of blood flow in capillaries of that imaged region, and we'll give it a 2D view of this, how the radionuclide has been distributed in the body. So there is 99 technetium HMPAO, which is used to evaluate the cerebral blood flow. There are EC tracers and technetium HMPAO that have applications in dementia. And TRODAT, it is a very interesting molecule which is a measure of a dopamine transporters and has been useful in major depression and especially in Parkinson. It has a role because in Parkinson it is the dopaminergic neuronal loss that occurs, and TRODAT is a measure of this. So there is decreased TRODAT uptake in these Parkinson disorders. I hope everybody has not gone into that default mode network and lost their connections here, because we are almost at the end. I will just touch upon 3-4 things. One is MR volumetry, which is just conventional MR, but now it is AI based, just like Dr. Vinay Kumar sir said that there are more AI based things that are coming in. So now AI can calculate volumes of whatever part of the brain you ask for, and you can implicate more and more studies on this. We can implicate what all involvement is there. Very commonly we use it for hippocampal volume. Schizophrenia, there is a role because it is the superior temporal gyrus that shows reduced volume. Also in PTSD, that is post-traumatic stress disorders, it has been found that a study was done on Vietnam combat veterans, and they found that there is reduced hippocampal volume in these people, and more the severity of combat exposure, more the stress, more damage it was there in the hippocampus. Spectroscopy is a measure of metabolite evaluation, producing graphs like this, and these are the various peaks that we get, and it has a role in identifying structural causes, as in high-grade astrocytomas wherein there is increased choline peak, in schizophrenia where there is lower bilateral NAS to choline ratios. Sndeep extensively talked about the other neuropsychiatric conditions in which there are affected NAS to choline ratios. Perfusion MR, which is basically a contrast MRI. It's not the same as the routine contrast MRI where a contrast is injected and post-contrast images are obtained. Perfusion MRI, it's a measure of vascular permeability, meaning it's a measure from how the contrast crosses from the arteries through the microcirculation into the tissues and into the veins. So that is how the perfusion is evaluated, and perfusion parameters are characterized, and it has a role in ischemia, neoplasms, especially differentiating radiation versus recurrence, and neurodegenerative disorders. In diffusion, as he said, especially in infarct, there can be a diffusion abnormality which is suggestive of an infarct in the same patient at the same time. If you do a perfusion scan and you see a larger perfusion abnormality suggesting that there was a smaller diffusion area, meaning area of ischemia, but larger perfusion abnormality, meaning an area which is more likely now to go into ischemia. Larger the gap, more likely it is that this there is a salvageable tissue, and an intervention like a thrombolytic agent is administered, then it can preserve this area where the perfusion abnormality has begun and has not yet become ischemic. Perfusion has a role in malignancies like this. When there are high perfused area, it suggests highly neoplastic pathologies, whereas when there are enhancing lesions but showing low perfusion, it suggests that it is possibly radiation necrosis, as in this case. Amide proton transfer imaging, it's a newer imaging technique wherein we image the proteins, and it is a technique where we don't give contrast and still we can identify, differentiate low grade and high grade gliomas, or differentiate true tumor progression from post treatment changes. And recently we've started doing this, and one of our DNBs had a thesis also on this, so we're gathering information on this particular new imaging technique. So I just wanted to show the images, as in this is an oligodendroglioma showing increased APT signal, and this was a high grade glioma, whereas there is another lesion which is seen on structural images, but on APT it shows less APT signal, and this is a low grade tumor. So to conclude, neuroimaging of psychiatric illness, it's a rapidly developing field. We have touched upon fMRI applications and the neuronal circuits that are affected. DTI, how the white matter tracts that are affected in certain neuropsychiatric disorders. PET-MR has a definite role, especially in cases of cognitive impairment, dementia, and Parkinson and autoimmune etiologies. And future is we can predict the oligosymptomatic or asymptomatic subjects. More and more we understand these modalities and bring it into application before they develop into a full-blown neuropsychiatric disease. So we have come a long way from just the clinical diagnosis to MR systems which give structural information, to advanced neuroimaging techniques like functional MR and metabolic evaluation with PET-MRs. So embrace these changes, use them in practice, and more they are used in practice, more and more insights we will get into these illnesses. Thank you very much for patient listening.
Thank you, Dr. Drushi Patel, for very nice and illustrative presentation. Definitely, it must have helped the residents joined here as well as the practitioners. So with this, I hand over the session to the chairperson of this committee, Pankaj Kumar.
Thank you, Dr. Drushi Patel, for the very comprehensive and very basic level of understanding of the processes and how it gives us so much information in different ways to understand the structure, functions, connectivity, changing pattern of plasticity. That was really, really very informative and very, very new to us. Though some of the things were not very clearly understandable, but we could understand the clinical aspects. And thank you very much, our chair for this session, Dr. Arun Marwale sir, for being here and chairing the session and giving us your time. So with that, these two sessions ends. Now it's time to start the question sessions, as we have put up in the chat box that please put up the questions in the chat box. And now I'd request Dr. Manik Vishay to take up questions from chat box. Since our first speaker has gone because of urgency, I hope the questions will be now mostly to be responded to Dr. Drushi Patel, which is, I think, Madam must be comfortable about that. So hand over to Dr. Mani. Yeah.
Thank you to both Dr. Sndeep and Dr. Drushi for very lucid presentation. And Madam, I would like to inform you that all these imaging techniques are now part and parcel of psychiatric curriculum. So there are separate chapters on each of these in our textbooks itself. So residents are also in that flow, and our intention was also to include residents so that they will be well versed with these techniques. These, especially this functional imaging is not available at most centers or most teaching institute, I will say. So thank you for enlightening all of us, especially for the residents. There is one question from Dr. Alim Siddiqui sir. It's a very simple question, but I think I'm just reading it out. A simple but difficult request. Please teach us to differentiate normal from abnormal in white and black MRI imaging.
All right.
White and gray MRI scan.
Entire radiology can't be taught in an hour and a half, right? But yes, I can make your life simple. See, MR brain has various sequences which are aimed at identifying, different things. Just from normal versus abnormal, I think the best bet for you or for anyone who is just looking for normal versus abnormal, look at the flare sequence. Most of the pathologies, they are bright on flare. Okay, so be it infection, tumor, infarct, all of them are going to show some amount of signal in the flare images. So normal versus abnormal, I think the first thing you can start off with is flare. And second most important sequence would be diffusion weighted images. I don't remember whether Sndeep said that also. So diffusion weighted images, there are two sets. Forget the physics. There are two sets that are acquired. One is the high B value image and the another is the ADC map. So when you have to look at both the sets to look at whether there is diffusion restriction or not. High B value bright and ADC map dark is diffusion restriction. And why diffusion restriction is important is because the most important ischemia, acute ischemia, shows diffusion restriction that you need to identify. You look at an abnormality in flare, you look at the second thing, abnormality in the diffusion, and you say whether it is restricting or not. There are multiple other pathologies which you look at the morphology on other sequences and say whether it is like an abscess or it is like a high grade neoplasm, which can also show diffusion restriction. But normal versus abnormal, look at flare. That is the most basic, simple thing I can tell you.
Thank you, madam. Any other questions? The chat box, it is not showing any more questions. Yeah, there is one more. Ma'am, in fMRI, the blood changes in brain have a time lag for few seconds compared to activation of neurons. Does it affect anyway? Is it considered as limitation?
The fMR technique, the blood changes that occur are still faster than the MR signal that reads it. So what happens is, whenever there is an activity, particular, say I am moving my finger, so it is going to be that finger area of the homunculus or the motor cortex that is going to be working. So when I move my finger, the blood flow to that particular area increases, and that blood flow related whatever I had explained, that is what is picked up by the MR signal, that is the bold signal. So by the time the blood flow increases and what is picked up by the MR, that is much faster than this. So it is that lag is in like micro milliseconds. So right now there are no such limitations related to that lag.
Thank you. Other question, please.
Yes, I have few questions if permitted, Dr. Manik.
Yes, sir. Please go ahead.
Yes, sir. One thing is related to OCD. I think in the presentation somewhere, Dr. Patel has specified in the context of MRS that there is increased glutamate in caudate lobe, and it has also almost has a diagnostic significance or value.
Yes.
How
So
much is the specificity of this finding? So that's an important thing.
this is, I did not put that in my presentation. It was
Oh,
Dr.
perhaps.
Satya who mentioned. So that is again a research-based thing that they had found where they compared the normal versus OCD patients, and they found a relative increase in the glutamate. Now these peaks are not very specific. There is a lot of overlap, especially when we do MR spectroscopy, and there.
Hello.
Am I audible?
Yes, Mr. Charan Kumar, please mute yourself.
Yes. So it is not that specific that if I see a glutamate signal, then that person is likely to be OCD.
Because we have been trying to take some without predictor models, particularly prediction based on the baseline functional imaging method through FNEOS, and we are trying to look at the what are the different. We are combining many kind of findings or classifier, combining electrophysiological also, functional also, and try to find what is the best way to predict it. So do you think, can you suggest any other way? Hello? Hello, am I audible, ma'am?
Yes.
Yeah, you are audible.
Oh, okay. Someone is putting all the time. So I just wanted one suggestion from you regarding what kind of multivariate classifier techniques we can use to further enhance the robustness or specificity of the finding of this study. This we are already doing as a part of one thesis.
So established cases, more and more they are exposed to these functional techniques. Would our data of clinical practice would improve this? Whatever the studies have been, they have been on animal models, and then there have been based on comparisons with the control groups. Frankly speaking, we have had 3 Tesla MR since almost more than 1.5 decade, and we don't get as many neuropsychiatric requisitions to just look at how the status of an FMR is in a schizophrenic, or look at how an FMR status is or DTI status is, whether the tracks are lesser than normal, because there is no control. So where we can actually compare. So research aside, these are the research findings that have been tabulated, but in clinical practice, we don't get as many requisitions to identify these neuropsychiatric conditions. More and more we do so, would our memory bank and data bank also improvise to add more light into it. This I am especially talking so for neuropsychiatric illnesses in fMRI and DTI. PET MR has a definite role, and it has already been established because of the newer avenues that have opened up in related to dementia and cognitive impairment disorders. Yeah.
Thank you, madam.
Thank you.
There is, I think, one question in chat box.
Dosage of triclophos, I have no clue, because it is the anesthetist. We just call the anesthetist, and it is his job to give whatever medication that he is comfortable with. And considering that there is not going to be MR, apparatus which can monitor it, so they usually use safe agents. Because they don't have too many monitoring devices which are MR compatible within the gantry. So it's the anesthetist's job or which molecule to be used. I just briefly knew what what are the agents. Different anesthetists, they use different things. So some use thiopentate, which is given very slowly IV. Some they use a combination of midazolam and fentanyl. More commonly and safely used is propofol, and we don't use as much. It can be used, but we don't use as much injection ketamine for anesthesia. Our purpose of the study is usually short sedation. Those whatever these advanced neuroimaging techniques take a little more time, more than 30 minutes, 45 minutes, if sedation is required. Otherwise, the routine studies usually take 15-20 minutes. So short sedations are required.
Thank you, ma'am. I have one question rather than a suggestion from you. Because whatever you presented, it seemed that PET is more specific than functional imaging, especially for the dementia and also for localizing the lesions in epilepsy and all. So, how much will be the costing? Because it is available in Maharashtra as well. But say if I have some patient whom I would like to refer, say for OCD or epilepsy, and I'm suspecting, as you said, temporal lobe sclerosis. So,
yes, any PET MR brain costs anywhere between 22 to 28, 29,000 depending upon different centers.
Okay.
Because it is a PET CT scan that is done, which is usually ranging from anywhere between 16 to 19,000, and then there is a full dementia MR brain protocol that is done, and then the software does the fusion, and then it is evaluated.
Yes, so it's quite doable. Thank you, ma'am.
Yeah.
So, as there are no other questions, I would just like to proceed with the vote of thanks.
Thank you.
First of all, I would like to thank the two speakers who volunteered for such an excellent sessions today. Special thanks to Dr. Sndeep Mevada sir, who was in hurry today due to some reasons, but
Manik,
yes,
can I have one question?
I'm
Sauji.
Yep, yeah.
I have put that in chat box, but it is missed. There are studies in clinical conditions, disease conditions, you can say disorder conditions, including dementia, where we look for cognitive deficits and the reasons. Are there any studies in mental retardation as such?
There are studies for, no, not that I particularly know of, sir. But there might be in literature, but no, we don't get these requisitions just for mental retardation unless they're looking for certain, unanswered clinical discrepancies. Then these techniques are opted for. So in practice,
I'm saying study in etiology. What actually happens in mental retardation? We talked since ages that this neurocirculatory doesn't develop and all that, and how does fMRI support that?
We don't get that in clinical practice. We don't get those requisitions in clinical practice. In research, there are papers related to which sites are particularly involved, but no, not in clinical practice, just to look at what and where the circuits are, what and where the areas of activation are. We don't get those kind of requisitions, unfortunately. But more and more we do all these things just for it is a costly affair just for doing research and getting the patient whether without having direct true implications in their therapy. It is more so research, and it's a costly affair, and that's why there is a limitation that these conditions, they don't come for evaluation.
Thank you, sir. So I will proceed with the vote of thanks. Thanks to Dr. Sndeep sir for making it to this session today, despite his hurried personal issues there. A special thanks to Dr. Drushi Patel for making the functional neuroimaging so readable to us. And we were with you, no doubt. Thank you, ma'am.
Glad.
Yeah. I would like to thank our office bearers, Dr. Vinay Kumar sir, Dr. Brahma sir, and Dr. Alim Siddiqui sir, for being here despite their busy schedules and enlightening us with their words. Special thanks to chairpersons, Dr. Tiwari sir and Dr. Marwale sir, for being with us and sharing the sessions. Thanks to all our members of IPS Biological Psychiatric Subcommittee. Dr. Sai Krishna Puli has been here throughout, and also Dr. Pankaj Kumar sir, and our EC coordinator and the advisors as well. A special thank to our university, that is MGM, it's a deemed university, for providing us this beautiful platform where we could conduct and record the session and would share the views and the very important aspects of neuroimaging in psychiatry with all the audience. I am thankful to management, the support staff who has been there despite their end of the today's working schedule. So thank you all for being here. So we will end the session here.
Good night.
Thank you. Thank you.
Thank you.
Thank you.